This is NNI Bites Big Learnings, a podcast where fellow healthcare professionals converse about the latest on nutrition science. Join us as Joseph Noe and Samantha Rodriguez share their knowledge and insights on neonatal nutrition.
Hello, welcome to Nestlé Nutrition Institute's special podcast, NNI Bites Big Learnings. I'm your host for today, Joseph Noe. I'm a professor of pediatrics at the University of Florida, and I am joined by Samantha Rodriguez, also from the University of Florida. She is a resident in the Department of Pediatrics.
Thank you, Dr. New. Happy to be here to discuss neonatal nutrition with you.
Thank you, Samantha. I'm going to start with just a simple question, and this relates very much to the article that was written. And you mentioned the importance of preventative strategies in this article for nutrition in low birth weight infants. What are some of the strategies you would recommend, and what is the evidence that they are effective in preventing some of the adverse outcomes seen in these infants?
Yeah, so I think that's a wonderful question. I think the biggest thing that we had found was starting early enteral nutrition was protective against a variety of different pathologies that we see that affect many of the low birth weight infants, including retinopathy of prematurity, necrotizing enterocolitis or intestinal injury, bronchopulmonary dysplasia, and it also helps to promote neuronal development. Prioritizing the mother's own milk or human milk is also extremely beneficial, and tried and true remains the most ideal form of nutrition for low birth weight infants. And being intentional about the abundance of amino acids also seems to be a particular importance, whether it be via parenteral nutrition or enteral nutrition, is it shown to mitigate the risk of BPD, of bronchopulmonary dysplasia, retinopathy of prematurity, and parenteral nutrition associated liver disease when done enterally.
Very good. So there are a lot of controversies about early nutrition in premature infants, and I know that throughout my career I have seen various phases where early on there was so much fear about putting food into the gastrointestinal tract of these babies that many neonatologists were very reluctant to provide enteral nutrition to these infants. And could you provide a little bit of information that relates to what happens when you don't put food into the gastrointestinal tract, and how this could be very detrimental for these low birth weight infants?
Yeah, so very much to what you're saying, it's extremely detrimental. There were findings of multiple folds of increase of neck with delayed initiation of enteral feeds, prolonging it. There's several different examples of it. Cochrane review demonstrated an increase in enteral nutrition, like at a rapid rate, had no increase in neck, comparing to two different rates at about 20 MKD increments versus 30 MKD increments, allowing for the increased optimization. I think the fear more so is coming from that idea of the immature gut and the very real fear of ongoing neck. But really the evidence has shown time and time again that early onset nutrition is associated with reduced incidence of spontaneous intestinal perforation, and the prolonged NPO days or no PROS or not getting anything enterally are positively associated with necrotizing enterocolitis or intestinal injury. So,
yeah. So there are many factors in the gastrointestinal tract that relate to having some food placed into the gastrointestinal tract. And one cliche that I hear very often is, if you don't use it, you lose it. And so there's something called a trophic effect, where some food in the gastrointestinal tract actually helps the intestine to grow through various factors. And if you don't put food into the gastrointestinal tract, if you only provide parenteral nutrition, you don't get that trophic effect. And you have various other factors, including hormones that are produced with the placement of food into the gastrointestinal tract. And some of these hormones can increase motility of the gastrointestinal tract, which is very important in terms of beginning to move food through and not having stasis in the gastrointestinal tract. So these are some of the very important components of actually putting food into the gastrointestinal tract. Samantha, could you name some or discuss some of the components of human milk that we think might be really important in terms of enteral nutrition?
Yeah, so human milk has a variety of different things that are extremely beneficial, specifically the immunoglobulins in the early stages in human milk, with specifically the IgA component helps as a protective mechanism for the gut. Um, Again, and particularly in this early immature gut, kind of establishing that IgA predominance in the gut through the maternal milk is beneficial for combating illness, the different growth factors, similar to what you were explaining with the hormone involvement, kind of contributing to intestinal development. The glutamine and human oligosaccharides are much easier to digest. Again, mitigating that risk of intense intestinal injury in these low birth weight preterm infants.
Yeah, and these you bring up the human milk oligosaccharides, and this appears to be a very important component, but they act as sort of a fiber, and if you only put the oligosaccharides into the neonatal gastrointestinal tract, they don't do much, but you have to have some helpers, and these helpers tend to be certain types of bacteria that are able to actually digest these human milk oligosaccharides and provide certain metabolites in the gastrointestinal tract. And some of these metabolites would include short chain fatty acids, acetate, propionate, butyrate. Butyrate is thought to be one of the very important metabolites, which has the ability to maintain gut junctional integrity so that you don't have translocation of bacteria through the tight junctions and have a inflammatory response induced. So I think that there are so many factors in human milk that are very important. And some of these factors actually get reduced considerably through the pasteurization process with donor milk. And so providing the baby's own mother's milk is probably the most natural and also the most helpful way to provide protection for these babies. So what do you think are some of the special areas of research interest in neonatal nutrition that may provide new avenues for prevention, for prevention of some of the adverse outcomes that we see in these babies? And I include adverse outcomes such as retinopathy of prematurity, bronchopulmonary dysplasia, growth failure, just as examples.
Yeah. I think similar to your interests are looking at the microbiome as going to allow us to have more targeted nutrition strategies. Being able to individualize nutrition, considering the different disease states. Every infant that goes through the neonatal ICU is so unique with different disease pathology. And so I think developing further into that microbiome is going to help us be more targeted in how we're managing their nutrition and their growth, their development, and what things that we need to optimize, be it if they have different renal disease, are they activating enough vitamin D, or do we need to supplement more in their nutrition, or additional protein or caloric intake if they're with congenital cardiac defects. I think looking into more individualized nutrition is going to be the next wave of the future of where we're headed in the neonatology.
So What has one of the things that has happened over the past couple of decades in neonatology is that we are going more from a best guess approach from the specialists in the area to randomized controlled trials and using evidence-based practice. And I think that this has certainly been very positive. And this has provided guidelines for nutrition of our low birth weight babies. And what do you think about these guidelines and a guideline-based approach? And are there pros and cons of a guideline-based approach?
Certainly pros and cons. I think that it's important to have these guidelines so that we can have at least some type of blanket. This is how we're going to manage and what is safe. How far can we advance safely? The different how quickly can we increase the enteral feeds on a daily basis or every 2 days. Those increments I think are important to know what we can do safely, but always with the art of medicine, thinking critically and looking at how the patient is tolerating it. But I think having those guidelines um, being applicable to the general patient or the traditional patient without all the additional medical complexities, I think that's where we will find the most benefit from standardized nutrition. Where we get into the weeds of it is the unique patients with a variety of congenital defects or anomalies that would require more individualized care. But having those guidelines will be beneficial in making sure that we are moving the ball forward with all the infants and making sure that their growth and nutrition is optimized, because we see time and time again that when we're not necessarily following guidelines, that we have delayed growth and failure to thrive, osteopenia, all these morbidities that we see in preterm infants, especially of the low birth weight population.
Yeah, yeah. So it seems like guidelines have been very helpful in terms of preventing chaos in neonatal intensive care units. And you have one neonatologist that comes in one day, another neonatologist that comes in another day, and the practice changes markedly from day to day. And so guidelines seem to help, at least with that component of care for the babies. But I think we still have a long ways to go because what has been happening in neonatal intensive care is that we now have these 22, 23-week preterms, which are very different physiologically from the kind of babies that we used to more commonly take care of several decades ago. These are babies 30 weeks gestation. And so it's a new era where we have to have some more precision and individualization, because certainly a 22-week preterm is not the same as a 32-week preterm, and the needs are going to be very different. So I think that we may be not applying all of these guidelines, which are meant to be toward the average. We are going to begin to learn how to do more precision-based and individualized care for some of these babies. This is going to be a major challenge in the future, but I think that some of the technologies that we have available now with artificial intelligence and multiomics should provide some real benefit in terms of moving forward in these areas. Do you have any other comments on that, Samantha?
Yeah, I think the idea of artificial intelligence is going to be immensely helpful in future research and where we're moving as far as individualized nutrition, or even establishing more guidelines that would be more applicable to these unique populations rather than the 32 to 36 weekers, these extremely low birth weight or extreme extremely premature infants are going to require a whole new set of guidelines. So I think looking more into using artificial intelligence is going to help us go through a lot more data a lot faster. And now they have artificial intelligence that's learning code and learning how to navigate through these immense data sets that we just never will have the time to do as individuals. So using artificial intelligence, I think, is going to be extremely important moving forward and going to help advance the field tremendously.
Yeah, I think that teamwork is going to be very important in terms of both the research and clinical care in the future with this sort of brave new world. So thank you very much, Samantha. This has been a wonderful session. And I'd just like to wrap up here by saying that we've come a long way in neonatal nutrition, and a lot of the dogmas and fears that we've had in the past, using some of the evidence-based techniques that we now have, we've been able to alleviate some of these dogmas and fears about providing enteral nutrition to our low birth weight infants. And we also have improved techniques of providing parenteral nutrition. But we still have a long ways to go. And if we continue with our trajectory toward saving these smaller, more fragile babies, we're going to have to develop ways to take care of them and for them to have good outcomes and prevent some of the adverse effects that we see in the neonatal intensive care unit. But even beyond that, these individuals are going to be living 80 plus years, and we'd like to provide for them whatever we can to make those healthy years. So thank you again, and I'd like to thank all the participants and the healthcare providers that have participated in this session. It's been a real pleasure to be able to present this to you. Thank you, Samantha.
Thank you so much, Dr. New. Very much appreciated. And this was a wonderful back and forth conversation. I think this was immensely important, and I hope all the listeners are able to take something helpful away that'll help with their clinical management or how they practice.
And that concludes today's episode. Thank you for joining us with Joseph Nui and Samantha Rodriguez as we talked about neonatal nutrition. We hope you enjoyed and learned from this quick discussion, fellow experts. Till the next episode.